Alrighty, so welcome everyone to the Society of Thoracic Surgeons General Thoracic Surgery Database monthly webinar. Today is Wednesday, August the 13th, 2025. So thanks everyone for joining today. On the call with me from the STS side, it's myself, Emily Conrad, Nancy Honeycutt, Ruth Raleigh, Banu Yahtzee, and Paul Meehan. So thanks for joining everyone. In terms of our agenda, I have just a couple of super brief STS updates. And then I'm going to, for our new data manager education today, we're gonna do a preview of the new data collection form. So we'll do that for our educational content today. And then at the end, as always, for Q&A, please be sure to use that Q&A function. If you would like to raise your hand to ask your question, you're more than welcome to do that. Just make sure that your microphone is enabled on your end. So thanks everybody. All right, so let's go ahead and hop into our STS updates. As you're aware, the fall 25 harvest is currently underway, and that does include our surgery dates of July 1, 2022, up through June 30th of 2025. The harvest is scheduled to close September the 5th, and our opt-out date is September the 9th. GTSD audit is currently underway. Notification letters were sent to those sites that were selected on Monday, on Monday, July the 14th. So if you did not receive a letter, then you can rest assured that you were not selected for audit. Alrighty, and just a friendly reminder that AQO 2025 is just around the corner. So that's coming up very, very quickly. Speaking of AQO, again, just a reminder for those of you, if you have not yet registered, and are still planning on registering, can you just give us a little thumbs up so we can see if there's additional people still planning to attend, but not yet registered. So if you could just give us a little thumbs up, but just a reminder that the dates for AQO are the 25th through the 26th down in San Antonio, Texas. Our GTSD session is going to be held on Thursday, the 25th. We will be at the Grand Hyatt San Antonio Riverwalk. And as you all are aware, we have both the in-person and virtual options. Just a reminder that if you do register for that virtual option, that is not a live stream. All of the in-person sessions will be recorded, and then you will have access to that content about a week or so after AQO. So, but just note that the virtual sessions are not a live stream, but they will be available. Is it typically a week or so after AQO, Emily, when that virtual content's available?
I'm gonna say 2 weeks.
2 weeks? Okay.
Because
Yeah.
I go through and edit it and then upload it, so it just takes a little bit of time with rendering videos.
Okay. Cool. All right. So yeah, expect the virtual content to be available about 2 weeks after AQO is over. And again, here's just information. You can register on our STS website. And if you have not been out on the website, we do have the agenda posted. So I just wanted to go through that really quickly. So kicking off the day, we have Dr. Cedar, our workforce chair, giving a presentation on where we've come from and where we're going. Then Dr. Fedchko is going to follow him up with the preoperative section concentrated on the new version 5.26. Dr. Broderick and Dr. Cedar will be presenting the lung cancer section. And then after that, we'll have a quick little break. And then after our break, Dr. Kular will kick off our esophageal cancer section. Again, this is for version 5.26.1. Then Dr. Fedchko will be back, and he will give us a presentation on the lung cancer and esophageal cancer anatomy. And then Dr. Vallada will present on our lung cancer and esophageal cancer nodes. We'll break for lunch, and then after lunch, Dr. Vallada is back with our lung cancer and esophageal cancer histology. Dr. Toe, our workforce vice chair, will present Lung Cancer 101. And then Ruth, I believe, is going to be presenting some Lung Cancer 101 case examples. Then Dr. Blasberg will present our esophageal cancer 101, and then Kelly Kanabe will be presenting esophageal cancer case scenarios. And we'll have another break, and then at the end of the day, we'll have, Dr. Enra will be presenting on our post-op complications for version 5.26.1, and then Laura Schultz will be presenting some case examples. For this year, we did have 5 abstracts that were submitted for this year's AQO, and all 5 were accepted. All proposals were accepted. So we have each of the data managers will be presenting their abstracts at AQO this year. So we are really, really extremely looking forward to that. And then after our abstract presentations, the session will adjourn, and then we'll have a networking reception on the terrace. So hopefully you will be able to stick around and join us for our networking reception as well. So that is a quick glance at the agenda for this year. And also, for our on-demand content, we'll have presentations on the paraesophageal hernia, tracheal resection, thymus resection. Dr. Murphy will do a GTSD audit, and then Dr. Elizabeth David will do a on-demand presentation for GTSD research. So, and again, all of these sections, the thymus, tracheal, and paraesophageal hernia, will focus on the new 5.26 data collection form. And speaking of AQO and the new forms, like help, what if I'm not able to attend AQO? So don't worry. If you are not able to attend AQO, we will be providing an in-depth review of the new data collection form after AQO. We did this with version 5.21. So if you're around for version 5.21, we'll be doing the same thing for 5.26. And we'll have multiple webinars, and we will again walk through each section variable by variable. So we will be having these webinars post AQO. So if you have FOMO, don't worry, you will still have plenty of educational opportunities reviewing the new form and going through each variable. You'll have the opportunity to ask questions regarding the new form. All right. So speaking of the new form, so for our STS education today, we're just going to give a preview of the new data collection form. So please, don't screenshot and that think this has not been 100% finalized yet. We are just continuing to review, and this form is near final. So just know that final versions will be posted and available out on the STS website when they are made available. Just a quick overview of the new data collection form. Some of the highlights for this new form. This was not, we don't consider this, I know we've talked about this before, a quote major upgrade. In terms of upgrades, if you're part of other databases, this is considered is pretty much a minor upgrade. So the purpose of this new upgrade was to add fields to help us with predicting long-term outcomes. And speaking of the long-term outcomes, as Dr. Cedar has alluded to in some of his previous presentations when he's been on and at previous AQOs, the long-term risk models for GTSD are currently in the works. So you'll be hearing more about that at AQO this year. I'm sure Dr. Cedar will be touching on that. So those long-term risk models are currently in the works for lung and esophageal cancer. One of the major changes for this 5.26 data collection form is the neoadjuvant model variables have been incorporated into this data collection form. So we will no longer have the red cap form after this new version goes live. So all of those, the variables will now be collected in this new form or under this new form. The neoadjuvant data will now be collected on both primary and lung esophageal cancer cases. Currently, we are only collecting this data for lung cancer. So we will be starting to collect this data on both primary lung and esophageal cancer cases. There were some minor updates to the optional modules, nothing crazy. So we did have some minor updates, some adding variables, some taking away variables for the thymus resection, tracheal resection, and paraesophageal hernia sections. Post-operative events, not a lot of crazy changes to post-op events. We actually did not add any new post-op events, but we did remove 8 variables that are currently collected under version 5.21. All right. So with that, I'm going to pull over the a draft of the new data collection form so we can go through this. I think I'm going to hold on just a second. I may have to stop share really quickly. Let's see if I can get this form over here. I don't know why I can't get over now, but there we go. All right. So what I'm going to do now is I'm not going to go through a deep dive of the new data collection form. I'm not going to go variable by variable. Just going to go through each section and highlight, some of the changes for each of the sections. And like I said, after AQO, obviously, our speakers will go into more in depth of these changes in the new at AQO. After AQO, we'll come back. We will schedule webinars and we'll go through this data collection form section by section, variable by variable, and you'll have that opportunity to ask any questions that you have regarding the new form. All right, so with the new form, you'll just see that the new fields are highlighted in blue. So you can see here. So let's just go through each section here. So the demographics, obviously no major changes here to demographics. Also, there were no changes to the current admission section. Preoperative or preoperative section, preoperative evaluation. You can see we've added a few new fields here. We've discussed at multidisciplinary board, multidisciplinary meeting. We've just added a couple of child fields for aortic valve disease, mitral valve disease. We're now collecting stenosis insufficiency or combined stenosis and insufficiency for aortic valve disease and mitral valve disease. No changes to vascular history, endocrine, cancer history. We've previously preoperative chemotherapy and immunotherapy were combined. These are now broken out into separate variables. We now have preoperative chemotherapy and then preoperative immunotherapy / targeted therapy, still collecting when and for what disease. And we have added a new field of, did the patient receive neoadjuvant therapy for primary lung or esophageal cancer? Yes, no, patient did not have primary or lung esophageal cancer. So if you answer yes to this variable, you will now be instructed to complete section D, which is the new neoadjuvant therapy data collection section. Preoperative medication history, not many changes here. Albumin level measured, we've added psychosocial history, we've added vaping, living status, just a couple of changes there to living status. Sorry. And then for the neoadjuvant therapy data collection, so if you currently collect data for the neoadjuvant therapy, it is optional at this time, but if you are currently collecting data for the neoadjuvant therapy module, these questions will be very familiar to you. If you have not been collecting these data, then these fields, obviously would be new for you. But again, if you answered yes to the parent, did the patient receive this neoadjuvant therapy for primary lung or esophageal cancer? If you answered yes, you would be instructed to complete this section. So we're asking the pre-surgical therapy that was administered, immunotherapy alone, chemotherapy plus immunotherapy, targeted therapy. And then we have the child fields for each of those specific options, for each of those specific choices. I'm not even going to try to pronounce these medications because it's comical at this point. It's just not possible. So after these choices, our next questions are the number of cycles completed, did the patient complete the prescribed treatment, time from last treatment to surgery, and then the pathological response upon resection. Some of the fields that were previously on the red cap form, and you don't see them listed here, they are in the, you'll find them in the lung cancer section as we get down the form here a little bit. Diagnoses, not many changes here. I'm going to just scroll, try not to scroll too quickly to make you nauseous. Operative section, we just added a few choices for status of operation. Not many changes here. Procedures, we've added the thoracotomy with mediastinal and regional lymphadenectomy. We have added that procedure. Updated a couple of title name to the titles here, paraesophageal hernia / GERD, but otherwise no major changes to the procedures listing from the previous version. I'm gonna scroll down. We added the unlisted procedure nervous system. We did update a few of the names here, the labels here for these sections. We've now called this the thymus resection, tracheal resection, and paraesophageal hernia section. I don't know, Ruth, did you want to elaborate on any on the name changes or anything? Or you just...
We were just trying to be more clear with the name reflecting what we were actually asking to be abstracted, because I think that the section headers were a little bit confusing before. So this is really just clean up from the last version to this version.
Awesome. Thank you. We ECOG, we just moved this down to move this down in the form, and we did change the choices for ECOG is now called ECOG / Zubrod score. So we have yes, no, not a cancer patient and not reported, or no, cancer patient and not reported. So obviously we're still still emphasize the importance of capturing that ECOG / Zubrod score, as this is a risk model variable. So that these field did not go anywhere. All right, for our lung cancer section, here you'll see, the lung cancer, like I said earlier, the lung cancer and esophageal cancer sections are where you'll see the majority of the changes. Clinical staging done. We're now collecting the SUV max of the primary lesion if it's a PET CT. We've cleaned up the clinical stage method. I think we got rid of, I think we removed one choice.
We got rid of all of the child fields
Right.
for a piece of mediastinal staging performed. So now you'll just check the box and you're not going to pick mediastinoscopy as blah, blah, blah. All of those children are gone.
Yep. Thank you. I've got my, yep. All right, and then we cleaned up the form a little bit with like the descriptions for this TNM staging. We just got rid of all of the language for the definition for each one. All that information, even though it's not on the form, it will be included in the training manual. So we did add into classification for the lung cancer nodes. So we added into A and into B, and this will be based on, I think, the 9th edition, the AJ, the 9th edition. For the pathological staging, we added synchronous primaries resected, same encounter. We are now under the final paths tumor staging, we added T2. We are now collecting the lung cancer tumor size, molecular testing performed, yes, no, or unknown. And then if yes, then you would complete which mutation was identified. And then was the testing performed on the biopsy or surgical specimen. The PDL 1%, We are now collecting, brought this over from the red cap form. So yes, no, and then the PDL 1%, less than 1 to 50, greater than 50, and that's 1 to 50, the percentage. We have added visceral pleural invasion, lymphovascular invasion, and STAS present. Invasion of adjacent structures, we've added mediastinum. Lung cancer, no, it's just a change in the verbiage here. We just updated this to read as lung cancer nodal stations assessed, no other changes to the nodal stations information. Same pathologic end stage, we just cleaned up, just cleaned up the name pathologic end stage. And then again, added the N2 classification. Pathologic M stage, we added, I don't think we had that in the previous version. Did we? Yes, we did. Did we? Yes, we did. I'm sorry, that's TNM. So we had the pathologic M stage, we just cleaned up the name. We added MX and M1. Lung cancer histology, we broke out adenocarcinoma into 2 separate choices. Now we have adenocarcinoma mucinous and then non-mucinous. And then if it's non-mucinous, we added the primary histologic pattern present. And then as you move down, just some added language here for lung cancer resection margins positive. And then we have added distance from the invasive carcinoma to the closest margin. And then we added adjuvant therapy. And then if adjuvant therapy, is not none or unknown, then which specific chemotherapy, immunotherapy, or targeted therapy was done. Esophageal cancer section, we've added EGD to the clinical staging procedures done. And then for esophageal tumors, we've added T4A and T4B. We added esophageal cancer histologic grade. We had not asked that in the past. This was not included in 521, but so we did make sure that we included that here in 526. Abdomen approach, we just added thoracoabdominal, anastomotic method. We've just added this choice for cervical esophagostomy. And then down into our pathological staging, you'll see changes here. We've added total number of lymph nodes sampled harvested, that if the node sampled harvested is greater than 0, then we are asking the total number of malignant nodes. We are now asking for microsatellite instability, MSI, asking if that's reported, as well as we're asking the HER2 new status. We've also added the variable of adjuvant therapy for the pathological staging for the esophageal cancer section as well. All right, thymus resection. We've made a few updates to the thymus. Ruth, did you want to go through this section a little bit? Or did you want me to continue? I don't mind either way.
No, it's fine. I can go through this one.
Okay.
Okay, so we tried to make these sequences make a little bit more sense by building out the parent-child relationships a little bit more. So you're first going to answer myasthenia gravis, yes, no. If yes, then you're going to click through the treatment types. And then whether there's a thymic mass known, yes or no, which then becomes apparent to the largest size of that thymic mass. And then we're going to start collecting neoadjuvant therapy information for thymus resection. To the operative section, we just added the subxiphoid approach, which was a bugaboo with the last version, so that has been fixed. Another thing that needed to be fixed between versions was the addition of partial sternotomy and semi-clamshell to surgical approaches for conversions. And then I think the rest of the section remained the same.
Yeah.
Under tracheal resection, just a few small edits. So we added intervention, some intervention types there that you can see. And then for incision, we added thoracoscopic robotic as the minimally invasive procedures become more and more common. Under recurrent nerve palsy, we added a unilateral palsy as an option. And then just a couple of, did the patient have statements?
Yeah. And
Do you want me to
then,
go through perisophageal or?
sure, you do this one and then I'll take the postoperative events.
Okay. So under perisophageal hernia, we added preoperative medical antacid therapy as a yes, no. And then I think we got rid of a few options there. I don't remember off the top of my
Yeah.
head. And I don't have the other document pulled up, but I think
Yep.
we tried to
We got,
reduce the number of questions we're asking. People are having a hard time finding a lot of data. The data points that we're going to continue to collect, the surgeons felt very strongly about continuing to collect because they were very meaningful. So please know that each and every one of these testing options were scrutinized, and they are in, meaningful measures. If you want to scroll down.
yep.
One of the questions that had come up with the previous version is, did we want to collect hiatal hernia repairs that were not the primary repair? And the surgeons resoundingly said yes. So now we're going to very specifically call out whether this is a first reoperation or a reoperation that's, second, third, fourth, fifth, sixth, etc. And then we ask for the surgical approach used in the most immediate prior procedure, I believe is how that's defined in the new training manual. And I think that's all of the changes there.
Yeah.
Onward to post-op events.
Onwards to the post-op events. So for post-op events, like I said earlier, we did not have a lot of changes for our post-operative events. One of the first changes that you will notice is that respiratory failure was renamed to reintubation. No change in the definition, but we just cleaned up the long name for that variable to reintubation. And then our next change occurs down in the cardiovascular section. We're capturing atrial arrhythmia, but we did remove the ventricular arrhythmia requiring treatment. So that variable is no longer being collected for 526. All right, our next change is you will see that also under the gastrointestinal section, the only change that we had here is that we're no longer collecting ileus. So gastrointestinal, everything remains the same except we have dropped that ileus variable. And hematology, no changes. We did drop the entire urologic section. So we're no longer collecting UTI, urinary retention requiring catheterization, or discharge with Foley catheter. So we have dropped all of those variables. Infection, the only change here under infection is we did drop the other infection requiring IV antibiotics. So these three variables remain the same, but we did just drop that other infection requiring IV antibiotics. Neurology, everything remains the same for neurology with the exception of delirium. We did drop the delirium variable. So again, everything remains the same except for delirium. And under miscellaneous changes here, we added for type 2, the TPM, we added / pharmacological treatment. And for type 3, we added invasive. And then for Kyleek, you'll also notice that if yes or no, we're only asking grade now. We dropped the severity variable. So we're no longer collecting severity for Kyleek. And then our final section is our discharge mortality section. No major changes here at this time to the discharge mortality section. We did add the variable AMA for discharge location. So we did add that variable, but otherwise that is all of the changes to the discharge and mortality sections. So that's just a super quick glance at the current form in its current state. And I know we have some questions coming in, but that's anything else you wanted to add, Ruth or Carol, for this new form before we tackle some questions?
No, I don't think so. A lot of work went into these changes, and I think really, like you said, keeping our eye on long-term risk and being able to use that data in that way.
Yeah. Okay.
You want me to, I can go through some of the questions if you
Sure.
want. So when is this version going to go live, Leanne? We have a couple of people asking that.
Yes, January 1, 2026.
Do you know when the final version of 526 will be available? Because surgeons are going to need time to revise their note templates to add in the new sequences that we've added.
Yes.
And
So,
presumably remove the old ones.
Paul? I don't,
Paul?
Well, let me jump in.
yeah,
This is
Carol,
Carol.
you
I
want to
can
go
jump in, everybody. Yeah, hi,
Yeah.
everybody. So typically what we've done with the other upgrades when this, we needed to consider timing also at the site level for
Mm.
updating their templates or their, I forget what those fancy things are called in Epic. Those notes that auto-populate, or not auto-populate, but the templated notes.
Yep.
We usually send the specifications out to the vendors. The vendors begin building their changes into their software. They sometimes will provide us feedback about little updates that might need to happen or things that they're noticing within the programming that we might need to tweak. When we get the final okay and vendors are starting to get certified, then we post the final data collection form on the STS website. And that's when you'll be able to implement this. Usually I say we hope to get the specs out to the vendors in the next week.
Mhm.
I think that's the goal. And then they usually have our first vendor getting certified within a month. So I'm hoping by the time of AQO, we might be able to post out the final DCF, which then the sites could take back to update their templated forms.
Oh, nice. Excellent. Thanks, Carol Crone.
Mm-hmm.
I appreciate it.
I think that answers another question too, Carol. Another person asked, they wanted to make so they're currently doing direct data entry, but working with a vendor to transfer over. They wanted to make sure that their vendor was going to capture all of the changes in their build. But the STS process sort of manages that by giving the vendors the specs in advance with time to build.
Yeah, whether you're on the vendors or direct data entry, you'll have the new version when you're supposed to have the new version. So it's for procedures of January 1st moving forward, January 1st of 26 forward. So that will be available either through your vendor or through direct data entry, either one.
Right.
Yeah. And then just Mary chimed in and said dot phrases. Yes, that's what I was thinking of, dot phrases.
Oh, cool.
Thanks, Mary. And then just a quick question following up on that. So this would apply to January cases or December. This would start with OR dates of January 1st, 2026.
Mhm.
And the first analysis that includes that data will be the fall of
Okay.
2026.
Mhm.
I'm going back on mute.
I think the next question related to the version upgrade is, does the STS have any resources regarding medications that classify as immunotherapy versus chemotherapy, since the neoadjuvant model will be required variables now? Yes, Robert, we can include the resources that we have on that in the training manual for sure. But, new drugs come out all the time. Your internal pharmacists are incredible resources, and you can always use Dr. Google too.
Well, Dr. Google.
I think the rest of the questions.
Yeah.
Okay, Erin has a question. Greatly appreciate the transparency in showing us the rough draft version of this updated version. It's my understanding that vendors needed 6 months for programming, testing, QA, UAT, etc. Paul? do you wanna
Yeah,
answer that?
we give the vendors as much time as we possibly can. But the mandatory start date of January 1st of 2026, that has to do with analysis. So like that is really not flexible. And so we do the best that we can to get the specs out to the vendors. This one's not a difficult upgrade. This is one of the easiest ones I can do that I've seen in memory. So this shouldn't be bad. They shouldn't have trouble meeting this deadline. They've known it's coming, that we've talking about it with them. And they should be able to get this rolled out in time. And we think that they still, there's still plenty of time. So bearing any catastrophes that we're not anticipating, we're going ahead with the January 1st go live date. And we think they'll be okay.
Thanks, Paul. Thanks, Aaron. But yeah, this is honestly one of you and I have been doing data spec upgrades for a very long time, Paul Meehan.
Yes, we have.
So yeah, this one's pretty it's perhaps I'm not going one the easiest one that I've done since I've been here for a little over 19 years. So let's see here. We have some more questions. Heather, if you could just email me directly, ljones@sts.org. Your question.
Heather had a question about who would be a good resource for uploading or getting her data from Heartbase and then uploading it to the SCS. I would assume, Heather, that there's going to be a resource through your vendor. Oh, and you have your hand raised, so I don't know if you can unmute, but feel free.
Oh, Heather, did you have a question?
And
I think
Hey,
she's trying to.
can you hear me okay?
Yeah.
I actually oversee the cardiac surgery, so I have no problem with the actual uploading and doing all of that. It's actually just specific to some of the operative stuff and like what they're asking within the like especially the operative fields and things like that. Some of it I have a few questions on. So I just wanted to know, sometimes like I think for CT surgery we have some people who are just I don't know, Caroline, you would remember what do they call them? I'm pretty advanced on the cardiac side, novice, to somebody who's new to that, and you can connect with them and ask a few questions within the fields. I just don't have a problem from the uploads and all of that. It's just within the field itself or within the data collection form itself.
Are you looking for, are you talking about how to abstract a specific case?
No, just certain things like sometimes it's not super clear on, how many of the procedures you have to put in. I always see there's a primary you have to put in, how many of the secondaries, if some of them aren't applicable, which one do you choose? Is it better to choose one or not? There's a few things on like on the nodule. There's just a few specific questions I have on like the nodal stations and things like that. And then other than that, I'm pretty good. There's a few little minor details on things like that I have.
Why don't you email me your questions, and then if I can answer them because they're technical in nature, then I can
Okay.
we can work with the help desk. Maybe.
Perfect.
That sound fair, Paul?
yeah,
Wonderful.
I mean, if it really, all questions should go to help desk. Help desk _ STSDB _ help desk at sts.org.
No problem. I'm just
send all your questions there. We'll get it filtered out to the people who can answer it if we can't answer it ourselves.
Okay, thank you. I'm just on a time, so I'm trying.
Happy to help, Heather. Yeah. Okie dokie. Nancy, neoadjuvant therapy, how and where can we see our data? Nancy, I think just email the help desk, the STSDB.
Yeah, are you talking about getting data from the REDCap form?
Yeah, I think so, Paul.
Yeah, if that's the case, yeah, email help desk and we can help you through that way.
So, Stephanie, yes, the spring 25 harvest results did go out. Did not receive an email notification, but logged in today. When did those results go out? I'll have to check my inbox, but yes, there was an email announcement that went out announcing that the spring 25 GTSD harvest results. But yes, they did go out. But yes, they are finalized for sure. Let's see here.
Aaron wants to know if the COVID question is going away. I believe we did remove COVID.
Yes, we did.
Kim wanted to know most of their surgical I see that party sign down there for no more COVID. Kim wants to know, most of the surgical cases come from outside our facility. They've had a hard time getting the original portion. They had to drop the red cap form. Medical records and clinic aren't helpful. Any suggestions? I I don't have any suggestions off the top of my head, assuming that you've worked with your surgeon's office to try and get that information scanned into the medical record. If other people have ways that they've successfully been able to get records from outside of their facility for preoperative treatment, feel free to either put it in the Q&A or raise your hand and
Yeah.
what's worked well for you.
Stephanie, getting back to your question about the harvest schedule, about the harvest results available, that email was sent out on April the 28th. And the subject line was new GTSD executive dashboard and spring 25 harvest results released. So that was sent on April the 28th, and it came from the STS National Database email address. All right. And while we're waiting for any additional questions, our next monthly webinar is September 10th. And then we have the quality improvement webinar August the 28th. And then followed by that, we have AQO coming up very, very quickly. So again, if you have any additional questions, please feel free to just email me directly, or as always, any question, if it's not a clinical question, a clinical coding question, those questions should go to the help desk, stsdb_helpdesk@sts.org.
One comment for Stephanie, if you aren't routinely getting like bulk emails sent from the STS, you can usually put a ticket into your organization to have them whitelist the STS email addresses, like the email address that these bulk emails come from, and then it'll pop into your inbox instead of getting blocked or bumped into spam or whatever is happening. Just a thought. I know that helps sometimes.
Yeah.
Oh,
Whitney.
Q&A session prior to harvest deadline. I don't think we've said that yet, Leanne.
Yeah, I know we haven't said that. We can look at that. So harvest closes September the 5th. So Ruth, why don't we look at our calendars and
Yeah,
get that
we can get
scheduled?
that out today. Yeah.
Are the updated immunotherapy section the same information as the current temp fields for 521? That is the hold on, the current temp fields for 521. Hold on. I forget exactly what they say, but hold on. I have too many screens open, Dion. Hold on.
While you're looking for that, I'm gonna answer Kathy's question. Kathy was wondering if we could clarify the timing for receiving changes to share with practices to update their templates. What Carol said was, I think we're gonna try to have that out by AQO
Yes.
around-ish.
Yes. Yes.
It's the goal. Usually we try to have it available before AQO. Since we have sessions on it at AQO, we usually instruct the sites to download or print that out and bring it with them, or access it on their computer or phone, when, whatever device they're using at the meeting,
Mhm.
as we walk through it, so that they might be able to want to take notes on it or something like that. But for all the other databases, that's what we've done in past AQOs.
Thank you, Carol.
Welcome.
We will not be printing out data collection forms. STS, I know that we've done that in the past. I just want to let you know that it will be sent. Yeah, it'll be an electronic version that we provide prior to the meeting.
Awesome.
Thanks for clarifying, Emily.
Yes, thank you. I'm losing everything. Hold on. I'm sorry, hold on. I've got too many screens open. Hold on.
While you're
Sorry.
looking, Elise
Yeah,
is
thank you.
wondering, Carol, if even though this is in draft, if they can start discussing with their internal teams with the understanding that this is in draft.
Oh, no, I don't think no, we don't do that. Even though Elise, it might just be helpful to your site to have the draft form. If any changes are made, then we have version control issues and it's really hard to walk any of those discrepancies back once they're out of the gate. So we usually wait for at least 1 or 2 vendors to get certified before we release we'll still call it draft. But before we release that data collection form to the sites and post it on our website, just for fear of version control issues, right, Paul?
Yep.
We've been there and done that. I think we got bit one too many times.
Yeah.
Yes.
She clarified that she's not wanting a copy of the form itself, but she wants to be able to talk about some of the points like the added
Oh, yeah.
therapy, like et
Yeah,
cetera.
sure. That's fine, Elise.
Yeah.
We just can't release the data collection form yet, but you can certainly update your surgeons and team about what we'll be collecting.
Yeah. So yes, you're good. Yes. And then Dion, yes. Those are the same. Okay. I have so much open. I've closed out of all the things that I wanted to have open. I'm losing it over here. All right. Any other questions? Let's see. Any other questions? Going once, going twice. Thank you for everyone for holding while I lose my marbles over here. Trying to find everything. But any other questions? Anything anyone else wants to add for AQO or questions about the form? Let's see here.
Mary wants to go back to the schedule screen, please. There you go.
Here you go, Mary. That's an easy one. I can do that one very quickly.
The next webinar is after harvest close. We'll
Yeah.
definitely publish
office
hours.
Yeah.
Thanks again, Whitney, for reminding us to get that on the books.
Yeah, thank you. Office. I like our little office hours sessions. But yeah, so if you're not familiar with our office hour session, this is a webinar that we have prior to harvest close where it's literally just Ruth, myself, and part of the help desk team. We can help tackle any questions that you may have outstanding prior to harvest close. Anything you have regarding uploading data, understanding your data quality report or anything like that. But it's just a informal office hour session. It's a Teams meeting. And there are no slides or anything. We just meet and you can just hop in during that hour and ask your questions and we can try and get those answered for you rather quickly. So, but yeah, Ruth and I will meet and get a date and time set for that. And then we'll send an email out to all of our GTSD data managers, letting you know when the date and time is for that webinar. All right. I guess that is all that we have for today. Thanks everyone for joining. If you have any questions, please feel free to reach out. And we look forward to having you all join us at AQO and we can go a little bit more in depth on the form and then we'll do so yet again post AQO. So thanks everyone for joining. I hope today was helpful. Please just let us know if you have any questions. All right. Thanks everybody. Hope you guys have a great day.